Africa confronts the world's most dramatic public health crises. HIV/AIDS continues to devastate the continent, which is home to 11% of the world's population, but 60% of the people with HIV/AIDS.
Okay, thank you.
Furthermore, Africans make up more than 90% of the estimated 300 to 500 million annual malaria cases that occur worldwide. Of the 20 countries with the highest maternal mortality ratios, 19 are in Africa, and the region has the highest neonatal death rate in the world. But there are hopeful signs as well. An increasing number of people are receiving life-saving treatment for HIV/AIDS. Polio is close to eradication, and immunizations are on the rise. What limitations still remain in tackling cross-border issues like HIV/AIDS and polio? How do we combat the rise in non-communicable diseases such as hypertension, heart disease, and diabetes? What are the societal and economic impacts of the health crisis in Africa?
Good morning. Let me just say from the beginning, there's 3 physicians here who have never worked in this kind of situation with an audience as brilliant as you all and this kind of dialogue. So we're all quite uncomfortable, me particularly. And these device pieces, not something we use every day. But you have been extraordinary on the devices. I've been watching all of you do them. So we're going to just quickly introduce the panel. I'm Debbie Birx. I was at Ground Zero, Washington, D.C. when the epidemic started. I was actually active duty military. And at first, in 1983, we had a trickle of soldiers that were HIV infected, followed by an avalanche. Thousands and thousands of young 20 and 30-year-olds infected. As a physician who thought that we had cured cancer and knew we could do anything with our technology, to be faced with individuals in our age group dying from a disease for which we could do nothing. And it took us years to figure out anything. Dr. Julie Gerberding was in San Francisco at the time, also faced with an avalanche of patients. And Loures was at Brazil. And we'll be hearing about Brazil today because one of the first countries to really step up and face the epidemic. Now, Julie Gerberding is at Merck, but ran the CDC for a number of years during the early parts of the epidemic, now at Merck Vaccines, where she's president. And Loures comes to us from UNAIDS, where he's the #2 person really setting the policy and the direction for all of us on how to confront this epidemic. So I want you to pull out your devices, because we're going to try something and see if this works. We're going to go to Tag Cloud. Up. I heard there was going to be... Oh, there it is? Yeah. Okay. When you think of AIDS, what one word, you can only type one word, comes to mind today? One word. I love the people who are on their cell phones with those little teeny letters and can tap it out correctly. I've not been able to do that yet. Okay, we're populating. This is terrific.
Judy, I'm using your body, okay?
Yes, sir.
Yeah, you take it. No worries.
And while we're waiting for that to finish, we're going to continue with your devices, and we're going to ask a question as soon as this finishes populating. Oh, wow, we see a curable up there. Okay, this is going to be an exciting dialogue for the next 45 or 50 minutes. Because there is that one child that everybody out of our 34 million people infected, the one child who we think could have been cured. Okay, that's great. And now if you can pull out your devices, we're going to go to voting. So the vote question, how many people are infected today, right now, in Africa with HIV/AIDS? And I don't want you to have enough time to go to Safari and Wikipedia. Just pick one of the answers right now without... I know some of you can multitask amazingly. I've been watching you do it. Okay, I think if we can start that vote. Okay, this should get an answer. Now, for the panelists, we saw a big word, uncurable, almost the same size as death. So Wow. Okay, this is a brilliant audience. You're absolutely correct. It's nearly 25 million. As we started at the beginning, 35 million infected worldwide, 25 million in Africa. This is not like any other infectious disease that you would know about, because this is an infectious disease that once you're infected, it is not curable. You're infected for life. You either die or you stay on treatment. So it's a lifelong disease and requires lifelong dedication to the disease in order to stay healthy. So we're just going to go to a couple of slides. The other one went by too quickly, and I don't know if I can go back there. So in the early 1990s, as we were facing this epidemic in the United States and we've had first successful treatment, this epidemic had been smoldering in Africa unbeknownst to anyone until they started doing surveys in pregnant women. So pregnant women would come into the clinic and they would find now that 40%, 30%, 20%, 10% of all pregnant women were infected without any option for treatment. So 100% of those women, which was 40% of the pregnant women, 40% of the women of childbearing age, 40% of the teachers, the physicians, the nurses, were infected with HIV with nothing but a death sentence. And so we were confronted with these numbers. You can see that Southern Africa, Lesotho, Mozambique, Swaziland, South Africa, Botswana, all very high levels of infection. East Africa, 10-15% of the population and women infected. And then West Africa, the data from there. We had been so proud through the 60s and 70s of the amazing increases in life expectancy on the continent. And then HIV happened. And we talked the last couple of days how events happen and it changes the entire dynamic. Africa was on the successful path of health. And we had immunizations and everybody was doing better. And life expectancies dropped by 20 years because of HIV/AIDS. And then there was a moment in time where the world came together and the Global Fund and PEPFAR began. And that will turn us to the first question and to Dr. Gerberding. You were there. You were in the administration. You were running the CDC at the very beginning of PEPFAR. What do you think the US government was thinking, and what compelled them to take on this issue when there's so many health issues to take on? What compelled the United States to act?
You know, it's a bittersweet question because the determination to really engage in Africa with substantial investment to try and change the trajectory of the epidemic occurred, but it did occur late. It occurred after many years of smoldering infection and then awareness without really effective global action. But when the United States and other countries did step up, I think one of the primary motivations was the shock of recognizing just exactly how severe this problem was. Until you really step back and look at the statistics and you really understand what it means for generations of people on the continent, it was very difficult to make the connection between how we were seeing and living with HIV in America and what was really happening here in Africa. And I remember very early in my career, when I was still at San Francisco General Hospital, the profound recognition of the possibility of heterosexual transmission. Most people did not really accept that you could acquire this disease through heterosexual sex for a long time. But when it became overwhelmingly clear that the virus doesn't really care what mucous membrane it's attaching to or how it got there, the whole scope and magnitude of the problem really became clear. And I think there was, the shock of recognizing the magnitude. Second, the awareness that the magnitude was not only a tragedy of human health, but it was a tragedy for economic development, and that it was not going to be possible to continue to engage in African development in a meaningful way without dealing with the problem in a substantive way. But there was the third dimension to this that I think not everyone fully appreciated and may not fully appreciate now, This has to do with stability and national security. And we got visited in San Francisco in the early 1990s by the CIA because they had come to conclude that the impact of HIV in Africa was a major force of political destabilization, and that if it wasn't addressed as a national security issue, there was a danger that not only would more lives be lost from the standpoint of the disease, but it would be amplified by conflict, regional instability, and potentially even war. So I think all of those factors came together. One, the shock of how horrifying this tragedy was and the compulsion to do something meaningful about it. Second, the growing awareness among Americans that it mattered to them what happened in the continent from a humanitarian and a philanthropic perspective, but then ultimately the recognition at a policy level that it wasn't just an issue of development, it was also an issue of national security. And the stimulus, I think, to tip this over the edge of investment really came from leadership. Not just President Bush, but many leaders in the government and in Congress and in the religious communities and in the health communities around the world really stepped up and said, we can make a small investment, but it won't make a difference. If we want to make a difference, we're going to have to make a big investment. And this really is the single largest investment that the US government has ever made in not just a health issue, but an international aid issue. And I think it did make a difference, and I feel rewarded for that. But as Dr. Birx knows better than anyone, complacency is our worst enemy. And if we don't stay the course and continue to stay with this problem, we'll see a return to the pre-treatment era because we are beginning to relax our outlook and beginning to think that this problem's under control. And when I saw the word curable up there, it made my heart stop, because maybe it will be curable someday, but it is far from curable today.
That's great, Julie. And we're going to ask you to pull out your pads again. We're going to go to a vote, because you just talked about this large U.S. government investment. And if we can pull up the next vote question. And it really looks at how much money has the U.S. government spent globally, not domestically, globally on HIV/AIDS in the past 10 years. So, and if we can start that vote now. I just want to pick up on something else you said, Julie, about the security. I think the other thing that woke everybody up was a group of Uruguayan peacekeepers were sent into Cambodia in the 90s to help stabilize things after some of the issues in the conflict. And a significant number of the Uruguayan army came back with what we call HIV-E infection, a unique infection only found in Southeast Asia. And so now peacekeeping forces were confronted with the issue of deployments and infection, and the subtype found in South America is B. So they knew that they were only infected in Southeast Asia, and this was a real awakening for UN peacekeepers, and they really changed their prevention education based on some of those early findings. Okay, so you were brilliant, and very close to brilliant this time. So we've actually spent close to $40 billion just on HIV/AIDS. $40 billion over the last 10 years between the Global Fund and PEPFAR, focused on a comprehensive response across all countries engaged in the HIV/AIDS crisis. And so it's really been an honor to be part of such an incredible response. I'll just say something really quickly here. In addition to this large investment, if you watch the United States and our healthcare costs, our costs go up every year without providing more services. Within this program, we've been able to reach more people every year at a cheaper cost. So it's incredibly exciting to be part of a program that becomes more cost efficient and cost effective every year. And we're able to do that because of the partnerships with the host countries, the partnerships with the nurses and doctors who become more efficient and can see more patients every day. So it's really been extraordinary to watch our cost of delivering services go down every year when it's been the opposite domestically. So just to move on to, we talked early on Friday about Botswana, and we talked about countries having different responses, and then we talked about infrastructure and infrastructure development. But if you look at these two countries, most people would agree fairly similar in human capacity and human health resources, yet one country has had a magnificent decline in both new infections and deaths, and one country very close, same epidemic, has not. And it's these kinds of illustrations. Let's go to East Africa for just a moment. Same type of slides, new infections and deaths with the new infections in blue. Uganda was considered a success story. We all clapped for ourselves and said, together we're stemming the epidemic in Uganda, because you can see the blue line originally went down, but the blue line quickly went back up. Yet Kenya next door, both the new infections and deaths continue to decline. And we could look at pairs like this every day, matching the infection. But Luiz, I know you know a lot about Brazil, and you know a lot about Nigeria. So maybe you could talk about what you think has been the differences in the responses that lead to these kinds of differences in both new infections and death, contrasting Brazil's response to the epidemic to Nigeria's.
Thanks, Deb. First, let me say I love this methodology. The UN needs to learn how to do that better. We need to learn from you. This is great. Just to put on context the question from Debbie, one way to picture is Brazil is history. Nigeria is the future. What's going to happen in Nigeria in the next few years in terms of the AIDS epidemic is going to shape the future of the epidemic in Africa and globally. I will come back to that and why I see like that. But on Brazil, on history, the beginning was extremely hard and difficult. I started my career, I saw the first AIDS patients in Brazil. I am a doctor. I lost myself and my direct care, about 1,000 people, young adults, most on the 20s. There were days in the night that I could not leave the hospital because my own colleagues will not accept to take care of my patients. That was the beginning. That was things start. Jump to watch Brazil today in terms of AIDS. Brazil is treating basically everybody that needs. There is a coverage very close to 100%. There is prevention is working. Brazilians usually, we carry a condom in our pockets. And by the way, this condom is produced in the Amazon. It's an ecological one by the government. It's where the rubber is. And but also, for the audience here, we need more business here. Brazil cannot find supply sufficiently in the world to buy the amount of condoms that they need. That's for you as a business, and so help us on that. But most important than me carrying this condom, more than 70% of the young population in Brazil, they are using condoms in the first sexual relationship. This is a major, major achievement in terms of stopping transmission and stopping AIDS. What did happen to bring it to us that far? It was basically a convergence between leadership on one side and social mobilization on the other. And that's what the response to AIDS as a whole, to me, is the biggest ever international operation on public health. And it's very important to understand why we came this far, and Brazil serves it as a way to try to understand. But it was this convergence of these two factors that brought Brazil this far. The result of this convergence was, first of all, commitment in all levels, from the highest level, from the presidents down to governors and states. Money, just when the real was a little stronger, Brazil was spending close to $1 billion of its own money on AIDS, and that's what cost to come down. There is money needs to be involved. And third, there is a shared governance. There is a mutual accountability between the civil society and the government today. It's very difficult to drop the policies in Brazil because the society would not allow that to happen. There are mechanisms today for control that are operating and taking us forward. That went across the society. For instance, the Brazilian Business Council on HIV/AIDS has a fundamental, a key role in terms of pushing forward, in terms of developing prevention programs at the workplace, even treatment programs. The military has been directly involved. Deb spoke about peacekeeping. I work a lot with peacekeeping because of sexual violence, because of rape. The peacekeepers from Brazil, they have a school where they are trained before sent to the field. They are trained specifically on prevention of HIV/AIDS. And this is very important. Nigeria. I said Nigeria is the future. Nigeria has 3.5 million people living with HIV/AIDS today. And continues to grow. It's an epidemic that to very recently was largely unchecked, moving freely and moving forward. Nigeria treats about 25% of the people that needs it. I mean, Nigerians are dying of AIDS today, as I saw people dying in the end of the 80s. And Nigeria, people are dying of AIDS today in Nigeria, as they don't die anymore, for instance, in Morocco, where the coverage of treatment is very good and is expanding. The prevention of mother-to-child transmission is even lower than that. Babies continue to born infected with HIV/AIDS in Nigeria and in other places in Africa, what does not happen anymore in the developed world. Does not happen in Brazil, does not happen in Europe, it does not happen in the US. There are signs of hope, there is no question on the points that I raised before. President Goodluck Jonathan, very recently, he shared himself a meeting during 3 hours with the governors of 12 states where he decided, from the 37, where he decided to focus the operation, the control. That's a very important step. We hope that you follow with more money commitment. Nigeria spends 25% of their total need. The rest is coming from international sources in terms of dealing and combating HIV/AIDS. But again, if that's not checked in a very short time, gains in Africa may start to go back because of the size of the population. It's the largest country. 1 out of 4 Africans today is a Nigerian. And then you can understand and appreciate the dimension of the potential impact if this epidemic go unchecked. But I'm hopeful, and I will come back to that. Thanks, Deb.
Those are incredible points that you made about the importance of bringing together civil society and holding government responsible, as well as the importance of the business group. And I know I met some young Nigerian leaders and young business leaders, and I'm not even sure HIV is on their agenda because they're the generation that grew up thinking about, AIDS was just always there for them. So it wasn't new for them. And I think hopefully we'll get into some of the discussion where we can hear from young leaders about how, particularly business leaders, how they view this, because Nigeria most likely will pass South Africa in total burden of disease if we don't all work together now. So just to pick up where Luiz left off about differences between countries in their commitment to service delivery, this is just a simple slide that shows, these are all UNAIDS data, shows the coverage by country for prevention of mother-to-child transmission. This is an incredible positive story because the number of babies infected this year compared to a decade ago is half, We had over 500,000 babies infected. Now we have less than 250,000. We still have work to do. But you can see the gains are not uniform. They're not uniform across countries. And many of the countries that I heard from over the last 2 or 3 days, Angola, DRC, and Nigeria, Ethiopia, have very poor coverage. And that means that 30% of the babies being born there to HIV-positive moms are becoming infected. Totally preventable with service delivery coverage. And then if you look at adult treatment coverage, you can see again there's countries that are struggling with less than 50% coverage. We think you need a minimum of 50 to 70% coverage to really impact the epidemic. When you're treated with these drugs and your viral load, that's the amount of virus you have in your body, decreases, your ability to transmit the virus to others decreases. So it not only helps your own health, but it keeps you from giving the virus to others. So this life-saving drug is turning out to be a very important prevention tool for us to utilize also. But turning to Dr. Gerberding, if you could talk a little bit, you have been a real leader in women's health issues. Within the African continent, HIV/AIDS has primarily affected women. 60% of the infections are in women. They're infecting their children, and you have taken a very aggressive role, both in working in HIV, but also Merck Vaccines has worked very closely on developing HPV vaccines to protect young women from cervical cancer. We were finding that we were saving women from HIV, only to have them die from cervical cancer. And if you could talk a little bit about your perspective on that, Dr. Gerberding.
Yeah, you know, it's an amazing accomplishment to be able to reach that many people with antiviral therapy. But I remember just a few months after I became the president of Merck Vaccines, I was visiting the Infectious Disease Institute in Uganda because I'm on the board of the nonprofit organization that works in collaboration there. And I was in the clinic and I noticed a young woman waiting to be seen by the doctor with a pool of blood under her chair. And what was happening was she was bleeding from undiagnosed cervical cancer. So here she was receiving HIV treatment to prevent one life-threatening disease, but she had not been diagnosed for another very common infectious disease that was going to take her life because obviously she had late-stage disease and there was not advanced treatment available for her. I work for a company, one of 2 companies that has a vaccine to prevent cervical cancer. You can imagine my personal accountability and shock to see that this vaccine that we're making so available in the developed world was absolutely unavailable to people who needed it the most because it was A, not recognized this was a problem, B, there were no systems to deliver it, and C, it was too expensive for people to achieve. So I made it really a personal priority to try to understand this problem. And one of the things I realized was the relationship between HIV and human papillomavirus, or HPV, which causes cervical cancer, that if you have HPV infection, which includes genital warts and some other mucosal abnormalities, you're more likely to catch HIV if you're exposed to it. But if you have HIV and you have HPV, you're more likely to develop really bad genital warts and really aggressive cervical cancer. So the 2 viruses interact with each other and make people sicker from their HIV or more likely to get it and have more early onset cancer and more difficult to treat cancer. So you're right, the tragedy is we solve this problem over here, but we have neglected a very important force of mortality for the very same mothers that we're trying to find and treat from an HIV perspective. So what is the dilemma here? Well, the dilemma here is that the PEPFAR program and many of the HIV prevention and treatment programs were very targeted toward those diseases. And we had some work to do to allow people to see the importance of a more comprehensive approach. And no government, even the US government, can take on the total responsibility for the comprehensive care and treatment of people in other countries. But we can partner. And I think what we've learned when we try to think of sustainable models for HIV, HPV, and other important health issues is that the secret is to try to understand how to scale the program in a sustainable way. And partnership is absolutely essential. So one of the partnerships that is in play right now around the HPV problem is something called the Pink Ribbon, Red Ribbon, which is championed by many African leaders, including the first ladies of many countries. And one who comes to mind most importantly is the First Lady of Zambia, because she's a gynecologist, and she really recognizes how important HPV is. But she and other of her compatriots have been working in collaboration with something we call the Pink Ribbon, Red Ribbon Coalition, which is to say that as we build out the red ribbon for HIV, we add to it women's cancers, particularly breast and cervical cancer. And we try to think, how can we take the PEPFAR clinics, which are working so well for people, and add the breast and cervical screening and treatment services, and hopefully someday vaccination services into that paradigm. So in several locations in Africa now, there are nurses who have been trained to have very inexpensive approaches to screening and treatment for cervical cancer. You can apply vinegar to the cervix, and if there is early precancer or early cancer there, the tissue turns white because it takes up the vinegar and reacts to it. And the nurse can look at the cervix, and if she sees a suspicious area, she can simply reach for liquid nitrogen or a little very inexpensive cryoprobe, and she can immediately simply treat that area and cure the early cervical disease on the spot. If she sees something more serious, she can take a picture of it and email it back to the gynecologist in the hospital, who can advise her whether or not, yes, this is disease, treat it, no, this isn't disease, or this is bad, bring the person into the referral center for more advanced care. Using this is pennies to do this. It costs very, very little to do this kind of screening and early treatment. And even in the early stages of it, in especially HIV clinics where many women do have HIV infection and are at very high risk for cervical disease, they're detecting these cancers and treating them, saving lives on the spot in more and more countries in Africa today. So as we think about models for partnership, I think this illustrates the value of the innovation, kind of the disruptive innovation of cheap screening and treatment, the importance of the trained clinician, in this case nurses, who are fabulously capable of doing this. You don't need a physician or a gynecologist, but also the value of bringing the private partnerships into play. Vaccine companies, companies who make the referral diagnostics, Susan G. Komen, which is the cancer prevention, breast and cervical cancer prevention organization. In this case, the George Bush Institute that is helping to fund the development of these early clinics and buy the equipment and the technology necessary for it. The US State Department, who under Secretary Clinton's leadership stepped up and said, we will allow you not only to continue to think about breast and cervical cancer and PEPFAR, but we will help use the PEPFAR platform to achieve this broader health goal for the affected women, and really made it a centerpiece of one of her important health initiatives for global health. The partnership is young, it's African-led. As I said, the First Ladies are the biggest champions that we have, but it's really bringing together African leadership, helping to develop a broader health infrastructure in the countries, leveraging the private sector partnerships as well as the NGOs who are helping support the training and the service delivery. And I think will really amplify the value of PEPFAR to not only result in better HIV prevention and care, but assure that these women and their daughters who are at risk for cervical disease can live in confidence that that is not going to be the next wave of health issue that they'll have to contend with.
Great. Now we're going to just move quickly on, and we talked about the importance of treatment, and this shows you in Kenya how it's half the number of new cases by having treatment available. And we talked about there was hope and curable in that first slide. And this is the decline in HIV new infections across the continent. And you can see it's not equal. And finally, just talking about burden of disease, I told you how Nigeria was on a pathway to pass South Africa, even though their HIV prevalence is 5% compared to South Africa, which is 15%. By just sheer population, their burden of disease is going to be greater than South Africa soon, without a response. In fact, they have already surpassed South Africa in number of new pediatric infections that are occurring today. So we're just going to end the slides there. I want to be able to get to you all, but just turning quickly to Luiz about running UNAIDS and really setting the vision for all of us to be following in the policies. Can you give us, I know this is putting you way out on a limb, your thoughts of how HIV will look 5 years from now and how UNAIDS is looking at this?
I am very ambitious on this side. I think I put 5 years from now into a bigger perspective. Jim Kim, the president of the World Bank, just some time ago, he said that we can beat poverty by 2030. If we can beat poverty, we can beat AIDS even before. I truly believe that we can end AIDS. Taking the progress so far, taking what we have learned, we know how to do. The issue is not the virus anymore. The issue are the factors that are making people vulnerable to the virus that are unchecked. And that is the issue of young women in the relationship with the man. The rates of HIV among young girls, not even women, girls, pre-adolescents, adolescents, in Sub-Saharan Africa, is 3 to 5 times higher than boys of the same age. This is not the virus. This is the vulnerability of these girls that needs to be addressed, and fast if you want to stop this epidemic, but we can do it. In 5 years, Debbie, I think we can set some interim targets. Again, Jim King established an interim target to 2020 to go down as 90% of absolute poverty in the world. By 2020, and even before, we can stop transmission mother to child. We can stop babies born with HIV/AIDS. I have no question that we can do it. It needs a major effort between now and 50, but we can do so. In 5 years from now, we can double the number of people on treatment today. We expect to arrive in 2015 with about 15 million overall, globally, under treatment. We can push for 30 million by 2020. What will have a major impact, not only in saving lives, but also to prevent further infection. Because we know today that treatment prevents. The one that treats does not transmit. This is extremely important. Science told us that just a couple of years ago. And then we can move to 30 million. But definitely, we can go to the end. And the last comment on that, I always keep that in mind when I need to talk about AIDS, when I come to Africa, when I am in my office in Geneva. 10 years ago, The Economist published a cover that was Africa, the hopeless continent. Inside the magazine, there was all kinds of bad news, from conflict to AIDS. 1 year ago, The Economist, or a little bit more than that, published a cover, Africa is Rising. And they are recurrent on the issue. Just a few months ago, the online edition of The Economist was Africa, the aspiring continent, aspiring Africa. Can be done. There is no question. The point here now, what is fundamental for all of us, is how to make wealth, how to make growth have a direct impact on the lives of people. Deborah was speaking about life expectancy. That's so important. Just to tell you, 1 year that Africa gains in terms of pushing forward, pushing up the life expectancy in this continent, make it happen, a 4% increase on the GDP of this continent. It's good for business, invest on health. It's good for development, and we need to make this connection more and more. to continue to grow, wealth, resource, invest on health is not sustainable. And this is a fundamental issue, and I think not better than an audience like that, not better than a meeting like that at the Atlantic Dialogues, to start to address AIDS from that perspective. Don't address from my perspective as a doctor. I need you to address AIDS from your perspective as businessmen, your perspective as people engaged on development. Thanks, Dan.
So we're going to go to questions in just a second. Let me tell you, some of the panel has changed. There were some emergencies on the continent. The Minister of Health for Namibia, because I think you saw how successful Namibia had been in all elements, decreasing incidence of infection, coverage, preventing mother-child transmission, treating all of their population. The Minister of Health from Namibia was supposed to be with us. There's a little bit of a problem with polio. On the continent, where they're having some very critical dialogue, so he had to cancel at the last minute. And Luiz came to us, but Michel Sidibe from Mali was to be here, really an incredible leader at UNAIDS, and Luiz works with him daily. He was called by the Director General to go to Korea, so at the very last minute. And I think he's doing something very important in Korea, but not as important as this, I think. So this has been difficult. So we did have some really important African leaders that were supposed to share the panel with us. Just want to go back to a final question to Dr. Gerberding before we turn to your questions. Remember, HIV/AIDS came from, there's a chimpanzee virus that infects chimpanzees that chimps live very comfortably with the virus. They are not killed by the virus. It's transmitted to their babies, but it doesn't kill their babies. And through what we call a zoonotic transmission, it came from chimpanzees and came and adapted to man and adapted very effectively. And if you remember Friday with the back screen that had all of these lights connecting countries, those are flight paths that connect countries, and the virus spread to every continent except Antarctica without any of us knowing about it. So we worry every day about these new viruses that are in animals. We share a space with animals, we share a space with each other. And Julie, if you could just talk just a minute about global health security, avian flu, and why HIV really is a warning signal to us about improving our surveillance and understanding when new diseases are developed.
You know, people really understand why they need military protection, or at least the capacity for military protection, because they recognize that from time to time they either need to provide support for peacekeeping or support for defense, and it makes sense. But often people don't understand that we need the same kind of capability for infectious diseases, because they are even more potent and more violent at times than anything that human beings can concoct, and I think HIV is an example of that. Mother Nature is a fantastic terrorist. She knows how to create all kinds of infectious diseases that can either be spread globally in a heartbeat, like Dr. Birx just described with AIDS, or like we experience with influenza every year, or diseases that have extremely high fatality rates, like we see with certain of the hemorrhagic fever viruses, Ebola, Marburg, and so forth, that can suddenly appear in human populations and be transmitted very quickly from sick people and kill the large majority of infected persons. So we have to recognize that some people may be in Zambia and some people may be in Alaska, but from A to Z, we're all part of one global community when it comes to infectious diseases. And we have to have a global network of detection and a global network of response, and I think most importantly, a global network of shared responsibility for recognizing that with infections, it will never be those people over there, it's all of us. And so sustaining our defense system against infectious disease means investing in the public health entities and the laboratories and the surveillance systems and the frontline soldiers of this army, who are often our public health officials, to help keep the information flowing, the awareness high, and our public health army ready to step forward and help protect people when these situations arise.
Great, so if you can pull your devices back out. So we realized that HIV is not curable. There was that one case, actually there's two cases. It's very complicated to explain. They had to do with bone marrow transplants for the one case, and another case out of these 35 million and millions of deaths, there's two cases, and a child that we're still investigating. So if you can pull your devices back out, we'll go back to the tag cloud, and we'll go back to the one word now that you would use when you think now about HIV/AIDS that comes to mind. This is really helpful to us. You're educating us about how we need to be more effective in our communications, how we learn how to use these mics that make you sound crazy and all of your words get blurred. But we're working through all these issues. So if you can just put up one word that describes, that comes to mind right now, if we can set the clock, and we will populate as soon as you get those. And if you can think of your questions, we'll go to your questions immediately. Together, we have about 100 years experience in HIV/AIDS. So hopefully we can answer some of those questions, but they also have other expertise in other areas. So last time, one of our biggest words was death. We don't have many death anymore. We have a lot of hope. We still have curable. This is worrying me. I think we picked up on Luiz's comments about poverty and the role that poverty is playing in moving this disease around the continent. We have words about progress. This is great. So thank you all for doing this. It's really helpful and helpful to us, and we will be saving those, and we will take it back to our leadership to know how we can communicate more effectively. But if we could move to questions now, maybe we can leave this up, because I think it's very helpful. Who has a question? Yes, please. Oh, microphones. And I want to make sure that I'm seeing all the questions. Can we have a microphone down here, and we'll go 1, 2, 3, 4. And then we'll move to, yes, please.
Thank you. My name is Susana Cabrillo. I'm from Brazil, and I work at the World Bank in Washington, D.C. I'm not an HIV/AIDS specialist or a health specialist, but early in my career, when I lived in Africa, I was exposed to people infected by HIV/AIDS. And one of the progress, or one of the facts that make the Brazilian experience successful, I believe, is the access to treatment and the production of generic medicines. I understand also that Brazil, through Fiocruz, is working with the government of Mozambique to build a plant in Mozambique to produce generic medicine for treatment of infectious diseases. I would like to know if that experience could be replicated in other countries in Africa, if this is in the plans, because what I've seen in Africa is that there is very limited access to treatment, and I know that prevention is a multidimensional issue, that it's very complex and requires actions that go beyond just medical, specific. Thank you.
Yes, thank you. So Julie, you could talk about some of the work that you're doing with tech transfer and some of the work really done about drug transitions.
So I can't speak for all of the HIV drugs, because there are now fortunately so many of them, and I'll let you pick up on this. But I think the concept of access is an area where there has been a great deal of progress. And I was in San Francisco in the early days of HIV, when we really believed there was no hope of getting any drugs to anybody who couldn't afford to pay the ridiculously high prices that we were faced with at the beginning of the epidemic treatment cycle. But with the help of the financing institutions, with help of the Global Fund, with help of the companies allowing sharing of intellectual property for generic drugs, and just simply access pricing, which means you basically charge the amount that it costs to create a pill, not the price that the pill justifies based on health value. I think most of the important antiviral drugs are currently available to the poorest people in the world, and assistance is underway to increasingly do the kind of localization efforts. I can speak for certain vaccines where tech transfers, for example, my company is involved in a tech transfer with an entity in Brazil to transfer our intellectual property for a very important vaccine related to cervical cancer to Brazil so that Brazil can make that vaccine for Brazilians at a price that is affordable for Brazilians. So that idea of understanding how to exchange technology and to localize the production of medicines and products in the countries where they're needed is something that's beginning to make sense from a private sector perspective as well as from a global health perspective.
Okay, so we're going to take 4 questions. We're going to go here, here. Can we have a microphone down here? Go ahead while we...
Okay.
Okay. Okay.
I'm Carolina Alexis Thomas from Trinidad. I was former director of a national AIDS program in Grenada. And in the Caribbean, we have been known to be second to sub-Saharan Africa. But we have seen decreasing over the past 10 years. We have seen decreasing in our maternal mortality in terms of PMTCT. We've seen increase in ARVs. So given the scenario painted this morning, there should be more focus on what is happening in the Caribbean, since we are second behind Africa, to see what's good there and use it. And most importantly, what we are doing right now is integrating. So HIV is no longer a standalone disease. It's now part of our sexual and reproductive health initiative, which includes cancer, which includes maternal mortality, which includes even gender-based violence. So maybe some of those things can be introduced to the African continent.
Terrific. We're going to go here. And then we'll go into Nigeria. Then we're going to go... Okay.
Yes, my name is Ariete. I'm a journalist in Cameroon. I've seen that in Cameroon, the epidemic is decreasing. We are at 2%. But I'm really doubtful about this figure because we have many problems in Cameroon, problems of corruption. When you have the therapy, then some doctors will take them for the public health centers to their own cabinet, as we say in French. And sometimes you have people in the remote region who must come to big cities to have their medicines, and sometimes there are no medicine at all. And they say that in the case of exams of CD4, I think, yes, you don't have the money to go and have all these things that you should do to have your medicines. So it's very, very difficult, and people are still dying in my country, but we are supposed to have medicines for everybody, but this is not true for everybody. Thank you.
Terrific. And from Nigeria. Go right ahead.
It's indeed a privilege to be here and to be part of this discussion. My name is Rosalind John. I'm a colonel in Nigerian Army. I'm looking at the figure that he gave concerning HIV/AIDS as 3.5 million, and to say that the government is doing a lot, because for 10 years ago, we had about 11 point something million people in Nigeria living with HIV/AIDS. So 10 years down there, and we're here, you can see that we're doing a lot of advocacy programs. We're doing lots and lots and lots, trainings and some interventions by the government, the US government, and lots and lots. But where I'm going to this morning, it's on the soldiers who are going for peacekeeping, who are going to, for peace support operations and nation building. A lot of them, they move into these countries, war-torn countries, and women are vulnerable. Sex is being used as a weapon of war. What is the nation, what is the UN doing about this? Women are the people that are being attacked. They kill the men, send them out, burnt houses, maim and kill, and take away the women. Rape them, sleep them, do whatever they want, and then have children with them. What are we doing about that? That is number one question. My number two question is about the development of vaccines. I believe that, yes, we've done so much.
Is it a quick question?
This is a question.
Okay,
Yeah,
quick
the
question.
development of vaccines. Is it possible? Is it not time? Yes, I know researches are going on. Is it not yet time for us to find out, even if it's something that can bring down the CD count, reduce it to a reasonable level, that even when a woman is being raped, at least you will not get infected? Because this is where the problem comes from. In my country, Nigeria, when there's any problem, even the women in the market, the streets, everywhere, even in the hotels, you check into a hotel, they come in and you get raped. So that's where we are looking at. Is there no vaccines that one can look at to actually reduce the CD count to a bearable level, so that even when one is being slept with, you cannot pass the virus? Thank you very much.
Great, we're going to go to this question, and then there's two back there, and then we're going to wrap up. Oh, I'm sorry.
Thank you. Patrick Worms, World Agroforestry Center. I'm an interested outsider to this debate. Congratulations on the fantastic work being done on AIDS. Yet, as the introductory video showed us, the amount of health issues facing Africa go far beyond this debate. So I have a constructive question and a provocative question. The constructive question is, are there lessons from the fantastic international public and private effort to deal with AIDS that can be applied to the other diseases? And the provocative question is the focus on AIDS crowding out discussion of these other diseases? It has certainly done so this morning here, and crowding out investment in tackling these other diseases. Thank you.
Great, we'll take these last two questions, and then we'll wrap up for these excellent questions we've had. Yes?
Morning, my name is Bako Kantiok. I'm also from Nigeria, and I am into community development, and I've also focused in the same area of HIV and AIDS, especially in the community level. And I think there's not enough attention being paid to the community, because most of the problems you see are they occur there in the community. For example, the issue of education. My question is, do we spend, could it be possible that we spend more money on education than on treatment? Because you find out that the mentality of the ordinary man in the community, they think AIDS, the HIV virus is something diabolic. They don't see it as a social issue or a health issue, a public health issue. They see it as something being diabolic. If the parent in a family, if you lose, like both parents die of AIDS and the child is surviving, that child is branded a witch or a wizard. So these are some of the challenges we face on the ground. I've had to take in so many children, and we've worked with Save the Children towards it. So it's a big problem that doesn't really come out that much, but there are a lot of orphan and vulnerable children there, all relating to this issue of education and the mindset. So can we spend more money on education, especially in the community level? Thank you.
Great, and last comment question, and then we'll wrap up the panel.
Hi, my name is Fatim. I'm from the Gambia, and I promise I wasn't speaking to him about this. I was a Minister of Health for up to almost 2 years in the Gambia, to November. And I want to talk about non-communicable diseases, which is actually coming on the rise. Last year, I was in Zambia, where they were talking about cervical cancer, and I got exposed to the treatments, and today Gambia is also doing the same. Now, my question is in relation to health promotion and education. This needs to be seriously scaled up within Africa, because we're spending a lot of money on prevention and a cure, but not on the part of education. And it's very important because if up to the village level, up to the community level, they still don't understand in their local languages what certain diseases and certain diets mean. So I think we need to talk to institutions. We need to do more research to see how best we can communicate messages up to the lower level in order to really address the issues of non-communicable diseases, because it really is related to communicable diseases such as AIDS and so forth. But the area of AIDS, the area of cancers, the area of so many other areas, it's really affecting the communities today. Thank you.
Great, thank you. And so this is a lot of food for thought, very helpful to us, because we often are just in our little dialogue talking to health people who just think the same way as we do. So this was very helpful to us. We'll have Luiz and then Julie wrap up really quickly based on the questions that they've heard.
Thanks, Deb. Very quick on the peacekeeping question. The Security Council approved last year a resolution that focuses specifically on rape and sexual violence because of AIDS. It's the first time that the Security Council of the United Nations take an issue like AIDS for discussion. And that complements in part what Julie has already shared with us. You are absolutely right. It's part today of the peacekeeping mandate to work against rape, to punish, to educate, and against sexual violence. It's part of the work today. The report back by the Secretary General to the Security Council happened in 2014, and we are working to have some stories. I was in South Sudan a few weeks ago, specifically on that. I can give you more details after the debate. On the question of the very good two questions on the lessons learned and the investment. On the lessons learned, I think there is no option but to learn from. As I said before, that has been the biggest public health operation internationally that we ever saw. And it's working in many places. To miss that, you'll be a big missing. We have no option but to apply to other major challenges that we are seeing. On your question of the interaction and the partnership coming first, on the impact of the disease, you take the case of TB, tuberculosis, for instance. A major driver of tuberculosis today is the HIV epidemic. The people that have HIV, they develop tuberculosis easy, and they can die of that, and that complicates the whole picture. Dealing with HIV/AIDS has a direct impact on the future of what happened to, at least about tuberculosis in Africa and beyond. But I would insist in the point of the lessons learned. What we did with AIDS, and what I think the world has learned, that we change business in the way that we are doing things. On the investment, we need to change the paradigm. We need to look at sustainability, integrate more what we have learned with AIDS with a broader perspective in terms of global health and health in Africa. There are mechanisms to do that. Share responsibility today. Africa is rising, is growing, need to share more, to have more ownership of its own epidemics, and need to be part of an investment approach that does not go only for HIV, but benefit a larger health agenda. And on the third question, communities, that's to me a key topic in terms of the way forward. But allow me to say that the business as usual will not work. What we have learned about health promotion during all the years before does not work anymore. We need to change the business. Communities, they are not beneficiaries of programs done by governments. They are the center. And governments need to understand that very clear. Is to mainstream the community work. What you are doing in your community needs to be the center where the response starts. And that we learn from AIDS as well. The countries that did better were the countries that went for an inclusive approach, that brought not only communities, but brought to the center the people living with HIV/AIDS. And that has been a key step in terms of set up the international response. But very welcome your question. I think this definitely is the way forward. Thanks, Deb.
Great, thanks, Julie.
You know, when we started in HIV, we didn't know what to do. We didn't even know initially that it was a virus. And it's aggravating to not know what to do. But to not do what you know is tragic. And the situation that we are facing in the world of HIV around the world, not just in Africa, is a situation where we actually do know what to do. But in many cases, we're not taking the actions that we know can make a difference. And you asked two very good questions. I would say that the important leadership, important lessons learned in all of this is that first and foremost, we need imagination. We need someone who can imagine a world where this is not a problem and where health really is something that is not fraught with the disparities that we have today. You need leadership and leaders with courage, because it's very hard to do this. I know firsthand how hard it is to do this. Deborah knows even better than I do how difficult it is to move this forward with all of the conflicting political agendas and competing health priorities and competing national priorities. So it takes courageous leadership and a commitment to scale the investment proportionate with the severity of the problem. The difference with HIV/AIDS in Africa compared to many other health problems that we've addressed, including TB and malaria, is that for HIV, we finally began to scale the investment so that it was coming close to what was necessary to actually deal with the problem effectively. Most health issues we dabble in, and education is an area where we're still dabbling in really addressing the important information needs of people. I wish education was enough, but my experience through decades of trying to do prevention is that it's not enough just to teach people the facts. Everybody knows you shouldn't smoke, but millions and millions of people use tobacco. So there's more to behavior change than simply knowing, but education is certainly necessary. And we have a lot of opportunity now with the new technologies and capabilities we have to do a much better job at informing people and getting them on board. The provocative question about why aren't we talking about all of the other health issues, and I would love to have a whole dialogue on all of the other important global health issues, but I do believe that if we can continue to solve the problem of HIV/AIDS on a global basis, that we will have the capacity to solve almost any other health problem, because what it's going to take this problem to a different level on a global basis are exactly the same things that will help us have the infrastructure, the knowledge, the capability, and the systems that will improve our ability to deliver all kinds of other health interventions. Someday we'll have a vaccine for this problem, and maybe we can dream of a future where none of this conversation on this topic is necessary. But in my world of public health, when I look at global health issues, the situation with HIV in Africa is still job one. It is still the most prevalent, the most transmissible, the most deadly problem that we face as a globe, and we need to deal with it on a sustainable basis much more effectively than we're doing right now. So I thank you for the opportunity to participate in the discussion, and I hope there's lots of crosstalk when this is over.
And please send us, those of you we didn't get to your questions, you have the leadership of the top world agency that deals with HIV/AIDS. Your questions are very important to them. They make all of the policies that we deal with and we work through. So please send us those questions, because this has been very dynamic for us. We learned much more from you than you probably learned from us. Thank you to the German Marshall Fund and OCP for allowing us to come and share this space with you. It's really been helpful to us. We've learned a lot about infrastructure and water and lots of things that we wouldn't have known without spending time with you. So thank you.
And thank you, Debbie. So we're going to take a quick break, back at 12:15 for the last session. First, one of our regular sessions, but I just want to warn you, at the very end, we're going to do something really special. We're going to bring out two of our emerging leaders to reflect on what they've heard from the older generation over the weekend. And I think it should be provocative. So we'll see you in a few minutes.